Today's presentation is on pressure injuries and wound care. So if we can have the next slide, please. The objectives for today's presentation are to basically report the whys and hows that pressure injuries occur in older adults. You can see the pre-test question here, so maybe I'll give you a little bit of time to respond to that. So first question is, a purplish discoloration around the low back of an 85-year-old man who slipped and fell can be classified as one of the following. And then the second question is, a skin tear is best treated with which of the following? And then the third one, randomized controlled trials show that turning patients every 2 hours prevents pressure ulcers. And then some pressure ulcers are unavoidable. So Nicole, are you able to see how many people have responded to the poll?
Yes, we've got close to 40 have responded out of 61. So we're getting close here.
Fantastic.
Yeah.
All right, we'll just give it a few more seconds here. And then are you able to go to the previous slide, please? Yeah, there you go. Yeah, so just the objectives is the how and why of pressure injuries. We would want to describe how to prevent pressure injuries. And then finally, what are the treatment strategies? Okay, now we can go to the next slide, please. So the topics that we're going to review are the definitions of pressure injuries, the risks. We want to look at the assessment process and how you best document, talk about the prevention of wounds, and then the principles of treatment overall, touch a little bit upon the infectious elements of pressure injuries, and then finally to discuss when the moment is best for palliative care for chronic wounds. Okay, so if we can have the next slide, please. So pressure injuries are both impactful and very prevalent, up to 3 million adults in the US. It affects the quality of life. It also impacts length of stay in hospitalizations, as well as the 30-day readmission rate, which is increased in people with chronic wounds. A lot of skilled nursing transfers. There's a certain portion, and a fairly high portion, of people that progress to death. I often tell folks the story of Christopher Reeves, the famous actor who was Superman, who after his fall from a horseback ride resulted in paraplegia, and his death was due to sepsis from a pressure ulcer that he acquired. And remarkably, here was an individual who had millions of dollars for the best care possible, and he still succumbed to the disease or the condition. Okay, next slide, please. Next slide, Nicole. So there's different types of chronic wounds. There's what we're talking about today, which are pressure injuries, but there also are arterial insufficiency wounds, venous insufficiency wounds, as well as diabetic and neuropathic wounds, non-healing surgical wounds, wounds from malignancies and metastases, autoimmune and vasculitic wounds, and then wounds from trauma and burns. And I included the concept of Munchausen, where these are individuals that create injuries to their skin and integument. Next slide, please. So a chronic wound is one that fails to progress through the healing process, which involves hemostasis. There's an inflammatory phase, and then there's a proliferation phase, and then remodeling, and importantly, contraction. And I basically want to emphasize the idea of contraction because sometimes when we assess wounds, they appear to be getting smaller, and that would be true, but that is through the contraction process of fibrosis. And so there's this connection that you have to make between the fibrotic process and the actual wound healing, because sometimes the wound will start to contract, but it really has not healed. So there's a little bit of a separation in those processes. And then basically a chronic wound is one that doesn't heal after 4 weeks. So next slide, please. A pressure injury is some localized skin damage. It usually occurs over the bony prominences, and the pressure in combination with shear effect will result in a pressure injury. So you have to consider both the both elements there in prevention, of course. Next slide, please. So there's different stages of wounds. So the stage 1 is basically the skin is intact, non-blanchable redness. In people of color, you need to look for changes in coloration, usually a darkening of an area. There may be pain, and it may either be warm or it may be cooler skin compared to other areas. We progress to stage 2, which is a partial thickness dermal loss. It typically has a shallow open ulcer with a red and pink wound bed. No exudate or slough. You don't typically see bruising. And you may see a blister filled with either blood or clear serum. Next slide, please. So these are examples of stage 1. So you can see that non-blanchable discoloration on the left. And on the right, you can see the skin breakdown, but still see parts of the dermis there. So that would be a stage 2. Next slide, please. Stage 3 is more progressive. Clearly, it's full thickness tissue loss. You may see some fat tissue, bone, tendon, muscle. There's a lot of slough and also what we call a biofilm, which is kind of a, I don't know, it's best described as a slimy goo. And then you may find some undermining and tunneling. So that would be discovered by probing with a sterile Q-tip swab. The depth will vary, but again, it's a full thickness tissue loss. And stage 4 is basically down to bone. And so you'll find undermining and tunneling. It's very similar to stage 3, but just obviously more progressive. So I think we have a slide of the what those look like. Next slide, please. Yeah, so stage 3, full thickness. In stage 4, with you can kind of see the undermining and the 11 o'clock position there. Okay, next slide. And then finally, there's the unstageable full thickness loss, and there's a lot of slough and scab on that. So that basically an eschar, and you can't stage it because you don't know how deep it is, because there's this big kind of clot, scab basically on top of it. And importantly, a note on the bottom there is that leave any heel eschars alone. So if you see a gangrenous and eschar area on the heel, in the old days, they used to be debrided, and boy, that was a real catastrophe. So you just leave those alone. Next slide, please. So this is a deep tissue injury. This can occur from impact wounds, whether they be like a high air pressure versus a fall or an object falling on somebody. Basically, you'll see a purplish or maroon area of intact skin and or a blood-filled blister. Typically, the area is painful, firm. It may feel a little mushy or boggy. And again, the temperature may change. It may either be warm or cooler, but there will be some delineated differences in the tissue. And then eventually this area may progress and become covered with a thin scab, basically. And the evolution may be rapid and eventually unfold or unearth multiple layers of tissue, depending upon the depth of the injury. So it's kind of like a stage 4 injury, but sort of masked in the beginning. It's not always clear. That's a tough one to look at, particularly with falls, because you're going to see bruising, and so that clearly is deep tissue injury. And then the whole question is whether it progresses into a pressure ulcer. Okay, next slide, please. Yeah, so that's the on the left is unstageable pressure ulcer with a heel eschar. And you can see this kind of purple violaceous deep tissue injury on the right. Okay, next slide, please. So the general approach to individuals with both risk and that have a pressure ulcer is to evaluate the individual conditions and what their risk factors are. Are they malnourished? Are they able to move around and get about? Or are they bed bound or wheelchair bound, for example? And then you want to define and implement the interventions that are consistent with those needs and goals, within the recognized standards of practice, which, by the way, is a clue to the answers. The standard of practice is not always established on randomized controlled trials. And so, for instance, the turning every 2 hours is not really a randomized controlled trial. This is just some number that developed into a standard of care or standard of practice without any real evidence that that's the right amount of time to have somebody that's bedbound be turned on a regular basis. But the important point here is that the individual be monitored and evaluated to see if the interventions are working. And of course, a lot of the interventions take many days to weeks, and so a lot of times you don't know which way you're progressing, whether the wound is going to get worse or better based upon your approaches. So that's always the caveat, is the duration before you decide that your treatment is a success or a failure. Next slide, please. So in terms of wound documentation, you want to come up with the diagnosis, the staging. So it's a pressure ulcer versus a venous ulcer versus an arterial ulcer. You want to stage it, as we had just discussed. You also want to identify the location, and then the 3D dimensions: its length, width, and depth. Does it have any odor or drainage? Can you identify any tunneling by a sterile cotton tip probe? And then the character of the wound bed. Does it have slough? Is there sterile sanguinous exudate? Is there any purulent material? And then you want to look at the margins surrounding the skin. Are they clean? Are they macerated? Are they erythematous? And then also you want to look for edema. And so there's edema around the wound itself, but then also generalized edema. So like, is the entire leg edematous or not? So do they have lymphedema, for example? Next slide, please. Well, this is a little tough to look at, but it's a risk assessment. And so, you can get this from the downloaded slides. You can actually print this off if you want. And it looks at all the different elements that you want for preventing the pressure ulcers. And so one of the factors is to try to control moisture in really, what I would say, extenuating circumstances. Sometimes people need Foley catheters or bowel diversions, for example, if they're going to be long-term bedbound and you're not able to contain the moisture. One of the facts that I always had mentioned, particularly in nursing home care, was that the reviewers, the state auditors would come in and they say, oh, the adult depends. The adult diaper was wet, and therefore you weren't controlling moisture. And as a medical director, I would say, well, actually, the diaper is doing its job. It's wicking the moisture away from the patient. Now, if it was super saturated, then it's not doing its job anymore. So there's a difference between an adult diaper that has wicking features of pulling moisture away from the body versus neglect, where somebody leaves an adult diaper on too long and it becomes super saturated. Okay, next slide, please. So the risk factors for ulceration are inflammation of the skin or dermatitis. So these are all internal or intrinsic risk factors. Edema is a really big factor. So if you have swelling, whether it be to heart failure or lymphedema, you've got compromised skin that can break down very easily. Obviously, low arterial blood supply is going to increase the risk for an ulcer. And I think most of us recognize the fact that immobility is by far and away the biggest cause of skin ulceration. Also importantly to point out that long-term steroid use can thin the skin and cause breakdown. And then one of the final points there is the nutritional compromise. So these are people that lose a lot of body fat because they're malnourished or undernourished. And then they're sedentary, or they're bedbound or wheelchair bound. And I see a lot of patients, quite honestly, that are prominently chair bound or wheelchair bound, and they will watch TV with their feet extended out, and then they get softening of the heels, and they get unstageable pressure ulcers on their heels as a consequence. Some of the extrinsic factors that we need to talk about, I mentioned earlier about the friction and shear effect. Medical devices can cause pressure ulcers if left on too long. And we mentioned the importance of moisture, and then also pressure in the process of creating ulcers. Next slide, please. So in terms of moisture, this can come from sweat, urine, diarrhea. It can come from fistulas or wound exudates, and it does increase the susceptibility to pressure ulcers. One of the toughest things to deal with is, particularly in the bedbound patient, is Clostridium or C. difficile colitis. A lot of times these people are on multiple antibiotics and they become C. diff positive. And they have lots of loose stools, frequent loose stools that just gets into the wounds. And you can't do a diverting colostomy because they're infected. So it's just a real tough nut to crack. So strategies to avoid moisture-associated ulcers is to create or to use moisture barrier creams. These are usually oil-based or polymers. I mentioned about absorbable undergarments, such as adult Depends. Continence care, whether that means frequent toileting, or use of intermittent catheter, or a long-term catheter would be considerations. Really, you want to avoid instrumentation at all possible, because you set the patient up for urinary tract infections with Foley's, for example. Next slide, please. Yeah, so this is an example of this sort of ghostly erythematous sacral moisture-associated skin damage, right? So it's like paper. It's like disintegrating, I guess, would be one way to look at it. Sort of a cottony, almost like it's been blanched. So that's a moisture-associated wound. Next slide, please. So again, to avoid the moisture, use hydrophobic creams, absorbable garments, and maintaining continence as best possible. Next slide, please. So some of the prevention strategies for wound care, or preventing wounds rather, is to offload the pressure through pillows and foam wedges. You can use lifting devices and draw sheets rather than just dragging the patient across the sheets to reposition them if they're bed bound. And then the standard is to use every 2-hour repositioning. And I got to tell you, this is just from a medical legal point of view. Everybody hones in on this every 2 hours. There's it's stating that there's neglect if they can't demonstrate that they've been turning the patient every 2 hours. Well, they may be turning every 90 minutes. They may be turned every 2 hours and 15 minutes. I mean, really, there is no evidence that exact time makes any difference. And so I think it's important that within reason that there's an offloading process that occurs. And some people, you may have to do it even more frequently than 2 hours. Some research that I recall indicated that a pressure ulcer can occur within 20 minutes if the conditions are right. So again, the specified time is just very, very elusive, and the commitment has to be basically to help offload the pressures, where they're contacting and causing the skin injury. And then finally, the final point there is to float the heels. So basically, those are either fleece coverings for the heels or pillows under the calves if they're bed bound to keep the heels from touching the bed surface or perhaps the wheelchair footings. Next slide, please. In terms of mattresses, there's Medicare views that there's 3 different kinds of mattresses. The group 1 is the gel foam or water mattress. The group 2 is the alternating air pressure mattress or low air loss mattress. Most facilities and long-term care use and home care use the low air loss version. And then the group 3 are these huge, what we call, I used to call them Clinitron beds. They probably have different names now, but they're air pressure with circulating silicone coated beads, and you just basically kind of sink into this. It's like silly putty. You just kind of sink into it, and that's another very, very expensive, and again, not very evidence-based intervention for either the treatment or the prevention of wounds. Next slide, please. The plan for treatment is to be holistic, patient-centered. Want to assess in life expectancy and overall health status. So somebody that's terminally ill may have a different approach towards wound care. Excuse me for 1 second. Just need to clear my throat. So the person with end of life may have different expectations for treatment than for people that have evidence for functional recovery. We also want to address the psychosocial needs. Sometimes people who are bedbound feel totally dependent and need psychosocial support for addressing those new feelings of dependency. We want to treat the underlying conditions, and so somebody that has active heart failure, COPD, or other chronic conditions that are exacerbated, so too are going to cause problems with what we call peripheral oxygenation. Smokers are just terrible to deal with in terms of recovery because of their chronic hypoxia system-wide. That their skin is just really difficult to reverse once the damage has occurred. It's important to understand the patient's motivation. Sometimes there's depression that precludes cooperation and adherence, and then also pain. Sometimes people say, "I want to stay in that position. I want to lie here just like I am." Well, you're going to get a wound ulcer if you lie that way too long. Well, that's my choice. And so if they're fully cognizant of what their choices are, in those circumstances, you may end up requesting palliative care because the patient, is what matters most to them is that they stay in a comfortable position. And so if you can't manage that through pain medications or other modalities such as offloading the areas, then maybe there is no ability to intervene successfully under that circumstance. Next slide, please. The other principles of treatment, as we mentioned, are the offloading. If the wound itself has necrotic tissue or debris that needs to be cleaned up, so usually we call that debridement. And sometimes through either the debridement can occur through chemically, enzymatically, or through sharps, what we call sharp debridement. And generally, if you go through the surgical route, it requires some pain management prior to doing that. The coverage of the wound is important. The concept of airing a wound out is a wrong approach. I want to emphasize that. And so that's an important consideration, is that a lot of times people say, well, just, leave it open, leave the wound open to air. That's not the way wounds heal. Okay, in terms of other treatments that you want to make sure that you address the pain, not only if it's static pain, but pain with movement. Sometimes people that are not verbal, you have to look at their facial expression to see if they're grimacing. And then finally, you want to always have a balance of advanced directives and palliative care to see if the individual needs to be, if those end-of-life issues need to be addressed. Next slide, please. So there's different modalities for wound care. The most common is the ever-famous gauze, but there's others. There's hydrocolloid treatments. All of these are meant to create a sterile barrier. There's semi-permeable films. Typically, the films are used on skin tears. The hydrocolloids are used in stage 2s and 3s and beyond, for providing a moisture environment. Next slide, please. Hydrogel, foam, alginate. You see a lot of kind of seaweed-based alginate as seaweed. And these are, so the foam and alginate tend to be absorptive dressings, and they help control exudate. That's their best use. So if you've got what we call a weepy wound, you want to use foam or alginate as opposed to hydrogel, which is a cleaner, a drier wound with very limited slough or necrosis. Next slide, please. Again, a lot of possibilities here. You can use collagen, which generally comes as a powder or sheet, and its theory is that it deactivates some proteases that are in, part of the skin damage, and these are used in typically exposed wounds with minimal necrosis. Silver dressings, so Silvadine usually is used on burns. It has antimicrobial activity, and it can be used either impregnated in gauze or just on the surface. I mentioned about debridement. So there's enzymatic debridement, and so there's different versions of this, but these are basically enzymes that help get rid of slough. There's also people will use chemical debridement through a very diluted solution of common bleach, basically. Okay, and then there's iodine dressings too that we can, that are part of this mixture. Limiting feature there is, iodine allergies or contact allergies. Next slide, please. Yeah, I just kind of want to bring your attention to the bottom here. Again, these are a variety of different modalities, and honey, believe it or not, is a type of treatment. So you'll find these basically gauzes or gels that are that have honey in them, and they help both from an anti-inflammatory point of view, and they're also antimicrobial. Next slide, please. Topical antiseptics can also be debriding. So I mentioned earlier about Dakin's solution. So that's that dilute hypochlorite or bleach. You use that just very briefly because it can be cytotoxic and really cause more damage to the wound bed than actual healing. In terms of the petroleum jelly impregnated gauze, that typically is, for a wound that is very sticky, and you're and it's painful to take the wound off, from the patient. Next slide, please. A bunch of things have been tried. I don't know if I can endorse any of these. Basically, there's electrical stimulation, there's some ultrasound, negative pressure. You'll see those wound vacs, hyperbaric oxygen, and all of these have very, what I want to say, limited evidence that's convincing that they really accelerate the process or not. If you talk to people who are advocates for these, they'll say, "Oh yeah, you got to do the wound vac, the wound vac," and a lot of wound programs will have the wound vac, and basically it's like a suction cup, that you put on intermittent suction on the wound, and that helps draw all the bad humors out. And it's honestly, gosh, it's very medieval concept. It's the how do I want to say it, the theory is not really well founded. But anyways, that's my opinion, and I'll admit to that. There's others who are very strong advocates for wound vac therapy. Next slide, please. This is a big one, is nutrition. So in older adults in general, it's important to have 1.5 grams per kilogram daily. So that basically amounts to around 80 to 90 grams per day. And those are, if you think about it, those high protein bars, those are 3 high protein bars per day. And so you might be able to get your protein through regular meals, but probably not so much for most older adults, particularly for vegetarians or vegan forward diets. It's real important that they get their protein through legumes, hummus, peas, oats, quinoa. Next slide, please. So this is a big deal. A lot of times wounds become infected, and then, if they do, you need antibiotics. You may need some debridement. You may need some other interventions. But basically, you look for a fever or change in body temperature. Sometimes it actually can go down. So if you have hypothermia or drop in temperature, that may be an indicator of sepsis secondary to a wound infection. You might find increased drainage. There's warmth, pain, edema, all the signs of infection. Next slide, please. So basically, it does no good to swab the ulcer and send it off for microbiology or culture and sensitivity, because you're just going to get all crazy skin flora. You might get some drug-resistant organisms. But basically, if you have a pocket of pus or something that you've expressed from a tunnel within the wound, then those are fair game for swabbing and for analyzing for culture and sensitivity. Generally, topical antibiotics don't work, and you need systemic antibiotics. And it's important to keep the area clean from fecal matter and urine contact, which is irritating. Yeah, thank you for anticipating with the slide change. In terms of palliative care, these are individuals that might be considered for transitioning to comfort care rather than curative care based upon poor nutritional status. They may have inadequate perfusion because they have advanced heart or lung disease. They may have multi-system organ failure, and a variety of other things that result in there not being long for the earth. Next slide, please. So for those that are interested in mnemonics, you can use the treatment thing called SPECIAL. You want to stabilize the wound, prevent new wounds, eliminate odor, control the pain, infection prophylaxis. In other words, keep the area clean. Use absorbent wound dressings for open wounds, and lessen or reduce the dressing changes. So that's a general mnemonic that you can apply. Next slide, please. So to summarize, older adults are at high risk for developing skin ulcers for a variety of reasons. One being they have multiple chronic conditions. The other one is that their skin thins with aging, and they have a lot of falls. So we try to avoid falls, but once you're over the age of 75, you have a 1 in 2 chance of falling. Pressure injuries can result in serious harm and death, so those are important considerations. And that in terms of both risk assessment and risk factor intervention are really the key factors, like is the person bedbound, is the person wheelchair bound, and if so, what's your intervention, what's your schedule of getting up and offloading. So the operative word is offloading pressure. And then the other ancillary factors such as nutrition and so forth. And then the final point is that many wounds that we encounter, particularly in people that have longstanding chronic conditions and frailty or disability, those wounds are not going to heal. And so palliative care oftentimes is the better choice of intervention. So I think, do we have a case report after the slide? Yes. So let's get into this and then we can open it up for discussion. So we have a 75-year-old male who fell off of a 6-foot ladder, and 5 hours had passed before he was found because he was still on the ground. And he had a fractured right femur, which in the hospital was repaired. The admitting nurse documents a 7x10 purplish area in the sacrococcygeal area, and the skin is intact. The discoloration is non-blanching and it's symmetric. Next slide, please. So here's your choice. How would you classify the skin injury? Would it be A, deep tissue, B, C, or D, stage 1 through 3? And normally I'd ask everybody to put that into the chat box. Let me see if I can get to that. Yeah, so go ahead and put your answer into the chat box. Just pick your answer, if you will. Yeah, so I see a lot of people jumped right out over there and are putting A, so that would be the right answer. Okay, so next slide, please. Yeah, so the correct answer would be deep tissue injury.